Hi guys, I'm going to go ahead and do my lecture on the rest of oral and maxillofacial surgery. So I'm going to start on page 705, so you can go ahead and pull up that page. While you're doing that, I'll tell you that underneath these lectures every week, go ahead and type in your questions and I will answer them, of course, after the lecture. Same thing for your workbook page questions. So just please type them underneath the lecture so that I can see them and answer them. So go through your entire worksheet on your own. Try to answer them the best you can. The ones that you don't know what they're looking for, please ask me and I'll help you out as I always do. So on page 705, we're going to start with maxillofacial procedures. So I actually have Lacey, my skull, here with me today so we can talk about some of these skull bones. But I really enjoy doing facial fracture cases. They're very complex sometimes and they're cool to see, but that means they can be really lengthy procedures. So if you look at your fourth bullet point down, these can be really lengthy procedures, so you're going to need to pad all the areas very well. It also involves the manipulation of bones near the patient's airway. So this can be a big danger, so you have to make sure these patients are NPO. And if you don't remember what NPO means, which you should, that means nothing by mouth, so they shouldn't have eaten anything before these surgeries. So some of these patients could arrive already intubated or even with a tracheostomy tube. So just be aware of that with their airway. If you read a little bit further down, it talks about airway fire. So that's a huge risk that could happen during these surgeries. So you want to take care to avoid intraoperative airway fire. So if you look down, it says maxillofacial procedures are done near the endotracheal tube where the oxygen is coming into the patient. So that's why there's such a high risk of fire on these cases. So on that same bullet point, you'll see that it talks about a closed ventilation system. So these cases are going to have a closed ventilation system with use of a fire retardant endotracheal tube. So they have a special ET tube for these cases. So go over to the other side of the page. It talks about actually fixing the fractures now. So look at open reduction technique and know what that is, and also know what internal fixation means. So typically open reduction, we're making an incision, we're opening so that we can reduce the fracture, so we can line it back up. Internal fixation, that's where your plates and screws come in. We internally fixate it so the fracture is now fixed. With some of these cases, you're going to have grafts, so make sure you know all of your vocabulary. So autogenous bone grafts can be used, homogeneous bone grafts from a cadaver, xenograft material can even be coral, very interesting, and then surgical technologists should be expected to help assist on these cases because of that. So that means typically there's not going to be a surgical assistant, so you will be retracting and passing at the same time. So this is a good case to make sure everything on your Mayo is very organized, ready to go, and that way you can make sure you're using both hands, one retracting and one passing throughout the case. If you look a little bit under that, it talks about your eyes. So because your eye is so near where we're doing these procedures, because sometimes they'll make an eyelid incision to get to the zygomatic bone, you need to have corneal protectors for your patients. So if you don't remember what those look like, they're typically bright blue and they go right over your cornea, so that can shield you during the case. And they typically lubricate these so it can slide over the eye easily. Position. So for these cases, you're going to be in supine. The arms are usually tucked and we're going to protect those ulnar nerves. If you look at the draping, it is a little different than oral surgery. They're typically going to use a U-drape, so it's going to split like this and you can wrap it around the patient's head. So instead of just a 3/4 or half sheet, you get to use a U-drape. Okay, so let's look at your arch bars in your book on page 706. So before the arch bars, let's do anatomy real quick. So your mandibles, the biggest, largest, and strongest facial bone, and you want to know what it articulates with. It's got all your terms in purple for you in the book. So it articulates with your glenoid fossa, and that's right next to your temporal bone. So if you don't remember your anatomy, study your temporal bone and this joint right here. So temporomandibular joint, TMJ. So if you've ever heard anybody say, I have TMJ, my jaw pops a lot. TMJ is the name of the joint. TMJ syndrome is what you're having if you're having jaw issues where your jaw is popping in and out of place. So know your anatomy and that includes your coronoid process. That's your anterior projection on your mandible, and I got my skull right here to show it to you. So, anterior projection right here. That's what it's talking about. Okay, I'm gonna set you back down. So after your coronoid process on the anterior ramus, you also need to pay attention to the condyle on the back. So the condyle is posterior, whereas your coronoid process is anterior. So that's on page 706 and then on 708. I want you to take a look at the picture in between. So on 707, there's a picture of all of the facial muscles. So look at your temporalis muscle, right next to your temporal bone, of course. It's going to be attached to your coronoid process. So those muscles, you should definitely look over and be prepared to be tested over those. On page 708, it goes a little more into the anatomy. So just remember where your facial nerve is, and that can be affected during these cases. And if you don't remember, your facial nerve is cranial nerve number 7. All right, so